In today's session, we are going to go through some EDTs. So, continuing on with our series on investigations within ophthalmology, I wanted to touch on your electrodiagnostic tests and sort of having like a brief overview of what they involve. It is a very sort of commonly kind of glossed over topic. It's not the kind of best understood. I'm not going to put my hands up and claim to be an expert by any means. But I think both for your exams and sort of general clinical practice, especially if you're in your ophthalmology clinics or in pediatrics, it's useful to know what each of the EDTs are looking at because they all sort of correspond to different parts of your visual pathway. So the amount of clinical information you can get from them differs depending on the clinical context. So we're going to go through vision evoked potentials, ERGs, EOGs, and touch on just at the end with some dark adaptometry, and what each of these things are, and A, how they sort of are performed, and B, what they therefore essentially show in the normal eye. In different sort of clinical sessions when going through neuro-ophthalmology, I will then touch on EDTs and say what the EDT findings would be. So in today's session, I'm not going to go through all the different sort of problems that you can find on EDTs. I think as a step one with EDTs, really understanding how it works in the normal eye, I think is definitely step one. Then figuring out what goes wrong is, I think, a different task. And in today's session, I wanted to just focus on what the EDTs look like in a normal eye. So starting with vision evoked potentials, this is essentially the electrical activity of the visual cortex. So it's quite handy when you're using it to look at things like visual potential. So in patients who might have some functional vision loss or in patients who are nonverbal, it's very useful at knowing what a potential vision an eye should have. And it's essentially looking at the general apparatus. So it assesses the electrical activity of the visual cortex by flashing a light on the eye, or it's a sort of black and white checkerboard that kind of flips between the blacks and the whites as a sort of pattern VEP. Um, and there are two main things that you're looking at. So you're looking at the latency, so the time it takes to get a signal, and then the amplitude, i.e., how big the amplitude is. So if your VEP is essentially normal, what it's basically trying to tell you is that there's theoretically no problem with the eye, but there are other things that can be going wrong. So this is a very sort of crude measure. The benefit of a VEP is that it can sometimes give you a general understanding of potential kind of acuity as well. So it's not going to give you an exact acuity for the eye, but it can tell you that the eye should be able to see pretty well. So if it can't, you're looking for other problems as to what could be going on. And this is especially useful in children, or like I said, potentially functional vision loss. So then going into the meat of today's discussion, so looking at the electroretinography or your ERG, and this is specifically looking at electrical activity of the retina. So it measures the difference in potential, so electrical potential between an electrode that sits either on the cornea or your lower lid, and the forehead. And the normal ERG is what today's session is about, and the aim is essentially to try and explain what the normal ERG is and why it looks the way it does, so that you can then, when looking at different pathologies, understand why those ERGs look the way they do. So with a normal ERG, you've got two main waves. You've got the A wave and the B wave, and sometimes you might see a C wave. So the A wave is a negative response, and it comes from your photoreceptors. And then your B wave is a positive response, and it comes from your Müller and your bipolar cells. So what you can sort of appreciate is that without any electrical activity going through your photoreceptors, you're not going to see anything going through your Müller or your bipolar cells. So it's important to bear that in mind, where if you have an extinguished A wave, you're not going to see much in your B wave anyway. But that sort of magnitude can sometimes therefore be a sort of pseudo measure on how good your photoreceptors are. So if the magnitude of your B wave is not fantastic, you might not be getting a great electrical signal from your photoreceptors in the first place. So it's just remembering that the light obviously goes down to your photoreceptors first, and then that's where the electrical signal starts. So that A wave starts at your photoreceptors, and then the B wave is as the signal goes through your outer retina into your inner retina before it then reaches your ganglion cell layer. So um, that's where the kind of normal ERG is coming from. And then there's certain things that I looked at. So again, there's the latency, which is the interval between the stimulus and the A wave itself, and then the implicit time, which is the time it takes from the stimulus to then get that peak of the B wave. And that's the foundation of the ERG. So your A wave is the photoreceptors, your B wave is your Müller and your bipolar cells. And then you're looking at the latency, so the time it takes for a signal to even start, and then the implicit time, the time it takes for you to then get to that peak of the signal going through your Müller and your bipolar cells. And then there's sort of different types of ERGs. So you've got your full field ERG, which starts with your scotopic and then turns into your photopic. It's one test that's performed over a long time. And then you've got different types of ERGs with different types of machinery that look at either multifocal, focal, or pattern ERGs. So when looking at the full field ERG, this is your standard test and it records 5 graphs over time. And it's a general recording of retinal activity. So remember, this won't be able to localize your pathology, which means if you do have localized pathology, if you have a specific problem either at the macular or in the peripheral retina, a full field ERG may not be able to pick it up because it's a general response across the whole retina. So if your entire retina is generally working okay, but a part of it isn't, your full field ERG may miss that, which is where the benefits of a multifocal comes in, and we'll talk about that in a moment. So it starts off after 30 minutes of dark adaptation. So the patient is adapted to the dark for 30 minutes first. You then have a series of tests being done with a series of lights, and then the patient is then gone through 10 minutes of light adaptation. So the whole test is performed over approximately about an hour. But it starts off with the eyes being in dark conditions first. So with scotopic conditions, the first half an hour of the test, after half an hour of dark conditions. And then you're then giving them 10 minutes of light adaptation as well. So starting with that dark adaptation, so for the scotopic response, you have 30 minutes of the patient being in dark first. And then you show them a very sort of dim flash of sort of white or blue light. And the idea behind this is you're getting your rod response, which is that first graph that you'll see at the top. Now, there isn't much of an A wave here, but you do get quite a large B wave. And then what you're then going to get is, so after that sort of dim flash, you're then given a bright white flash, and then you'll get a combined response of both your rod and your cones. Now, remember, when you're getting the rod response, you only get the rods responding to a dim flash of light. So you're only going to see those cones respond, sorry, when you get a bright flash of light. Then your oscillatory potentials are slightly different parameters. So you give them another bright white flash, but this is essentially looking at how everything responds essentially within the B wave. So it's a sort of um, what you're looking at there is a sort of almost like a magnified version of that ascending B wave here. So if I use my mouse, this is the ascending B wave here. These oscillatory responses are happening along this wave. So everything is happening one after the other. So you give a dim flash of light first, you get this first graph at the top without much of an A wave. Then you get the second more sort of typical wave that you get with a rod cone response. And then you get these oscillatory potentials. This is with another white flash, but you change the parameters on the machinery, and these are happening along that ascending B wave. You then adapt the patient to light. So after you've done those 3 responses, you let the patient so you'll give some diffuse bright illumination in the room for about 10 minutes. You get the eye to respond to adapt to that light, and then you give them another single bright flash, and that will look at a single flash cone response. And then you start flickering light at about 30 hertz, and then again you get that sort of flicker response as well. Now, the way the eye behaves in both light and dark is important to understand as to what the basis of this ERG is. So in the dark, when the patient is adapted to dark light, the rods are much more sensitive than your cones, which is why you start off with those rod responses. But then in the light, the cones are more sensitive than the rods, which is why they're then responding to these single bright flashes of light. So that dark adaptation followed by the light adaptation then gives you that normal ERG, which looks, if I go back like this, where you get these 5 different responses, and that's your normal electroretinograph. And then you can have different types of ERGs. So with a multifocal ERG, it's very similar to the full field, but you have sort of different scaled stimuli. So you'll give stimuli at a different intensity of light, and that will essentially cause a different response depending on how densely populated the retina is, or that part of the retina is with photoreceptors. So you can imagine at the fovea, where you have a very dense photoreceptor population, you're going to respond to, or you can respond to slightly less intense stimuli compared to in the peripheral retina. And that gives you a sort of 3D plot. And this is a bit better at sort of noting focal pathology. Your focal and pattern ERGs, focal looks specifically at macular disease, so it looks within the macula. It doesn't focus on what's going on in the outer retina. And then in the pattern ERGs, it's very similar to your VEPs in terms of you're showing them this black checkerboard that flips between the black and white squares. And this essentially looks at your ganglion cell function. So it's also useful at looking at very subtle optic neuropathies, which is again what the VEPs are helpful for as well. Then looking at your electrooculography, so you may have heard things like ERGs, EOGs, and the differences between them. And with EOGs, what you're looking at is essentially the difference between an electrically sort of positive cornea and an electrically negative RPE. So it's essentially just the difference between the front and the back of the eye. And it looks specifically at the electrical activity of the RPE and photoreceptors. So what this means is that if your disease is within the inner retina, the electrooculograph will not pick it up, which is why you'll have a normal EOG. So for example, in Best disease, where you'll commonly come across the sort of your SBA and your multiple choice question answers as to what will give you an extinguished ERG but a normal EOG, it's typically Best disease because the disease is within the inner retina. So your RPE, your photoreceptors are actually architecturally normal, which is why you're then going to get that response with an extinguished ERG but a normal EOG. So remembering that the EOG looks at your RP and your photoreceptors, whereas the ERG also looks at that activity through the Müller and the bipolar cells as the signal kind of travels through into your inner retina. And there's a lot of variation with the EOG when you kind of look at the RPE as a whole. So an average is usually used. You take your sort of maximal response in light anywhere across the RPE and you divide it by your maximal response in dark. And that gives you what we call the Arden ratio. So it's usually 1.85, which essentially suggests that your maximal response in light is about 1.85 times the response in the dark. And that ratio is usually what's used or looked at when looking at electrooculography. And then finally, in this sort of kind of quick tour of your EDTs, we look at dark adaptometry. And this is essentially looking at how the eye adapts to dark conditions. This, these responses are going to be reduced in things like nyctalopia when looking at patients with, for example, retinitis pigmentosa. And the way you perform it is you first have to completely bleach the eye with light. So you have an intense light for enough time to bleach about 25% of your rhodopsin, and then you put the patient in the dark, and you as they sort of sit in the dark, you measure different responses, and you see how long it takes for them to completely recover and therefore adapt to the adapt to the darkness. And if you remember, when you bleach the eyes, the rods become very insensitive to light, and only as the eye adapts to the darkness do the rods become slightly more sensitive. So when looking at your dark adaptation curve, which is what you get with your dark adaptometry, you start off initially with just your cone branch. So the only thing that are going to be responding to light in that initial part of the darkness, when the eye has already been bleached with light, are your cone cells. Your rods are very insensitive to light in that first few minutes. So in the initial 5 to 10 minutes, only your cones are sensitive. And then suddenly there's a slight break where the sensitivity shifts from being mainly from your cones to then your rods. And that typically happens at 7 to 10 minutes, and that's when it's supposed to happen. And then your rod branch, which is much slower, much more gradual, this looks at rod sensitivity. So gradually, as the eye becomes more adapted to the darkness, your rods are going to be more and more sensitive, and they start being able to respond at lower and lower and lower thresholds of light. So you start off with much brighter light stimuli when you're looking at your cone branch, and you slowly and slowly get more dim. And then actually when the rods are fully adapted to the darkness, and this typically happens over about 15 to 30 minutes, you're actually able to respond to light stimuli up to about 100 times dimmer, that should say, not dinner. I was clearly hungry when I was making this presentation. They start to respond to light stimuli 100 times dimmer than what your cones would be responding to. So over 15 to 30 minutes, as the eye completely then adapts to the darkness, you should be getting these rod responses. And that's where you start to find the pathology in patients with, for example, something like RP. So just to summarize then, like I said, this wasn't going to be a very long presentation, but it's just a sort of tour of your EDTs. There are many, many different types, and EDTs are your branch terms, and an ERG is a type of EDT, and they all sort of work together to assess different parts of the visual pathway. So when you use them in combination with clinical findings, when you use them in combination with things like the history of the patient, the other investigations that you've got, like the OCT of your macula, a clinical examination of your retina, how the disc looks, um, and then that's sort of how they're used together to come up with a potential sort of pathology in the eye and what could be happening across the electrical activity. So that brings us to the end. Thank you very much. I hope this was useful. Please do remember to fill out the feedback. If you're watching this online, then again, that link is in the description. It's very helpful to me to know how these specific sessions are going, and there's a link in that feedback to then allow you to send me over sort of suggestions for tutorials or topic requests that I can do at some point. So thanks for joining, and we'll see you at the next one.